and thanks Penny as well for the run through to the website. Ladies and gentlemen, if you're ready, I would like now to introduce our honored guest speaker for this session, Dr. Suhail Suresh from Sunway Medical Center. Dr. Suhail will be talking about positive aging through healthy joints. And what he'll do is take you through the aspects and effects of positive aging. So Dr. Suhail, if you're ready, the floor is yours.
Good day, everyone. Thank you for listening to my talk. I'm going to talk about positive aging through healthy joints. My name is Dr. Suhail Suresh. I'm a consultant, orthopedic and arthroplasty surgeon from Sunway Medical Center, Kuala Lumpur. A joint is an important portion of our body. Without a joint, we wouldn't have much mobility. Life is a choice between aging and growing. Aging is adding years to life, whereas growing is adding life to years. So in order to have a positive aging, we need to have mobility in our life. I would like to first show a diagram of a cartilage and a joint. And in this picture, we would be able to see on my left-hand side, a diagram of a knee joint. We would be able to see the end of a thigh bone and the beginning portion of the leg bone, which is the tibia. And this white structure is the cartilage, which is the soft bone between these two bones. And this cartilage is covered by a synovium or a lining which produces fluid into our joint and absorbs the fluid. Now, in an osteoarthritis, apart from the cartilage which is degenerated, which you can see in the right side of the picture, we also have the synovium, which is colored in red in this diagram, becoming inflamed and painful. Now, degeneration of a joint cartilage has got 4 different categories. On my right side, you'll be able to appreciate a picture of a bone and the cartilage, which is like a cap, which is white in color. Now, in the early phases, this cartilage undergoes early degeneration, whereby there is cartilage fibrillation and early subchondral bone sclerosis or hardening of the bone. As time progresses, that cartilage will become thin, and eventually there is a microfracture within the cartilage, and that eventually progresses to forming cysts because of the fluid entering the joint spaces or the cartilage spaces. And that also forms these spurs on the sides of the bone. Now, if you do a cross-section of this bone, you'll be able to appreciate the picture on my left-hand side, which is the bone, which is yellow in color, and the white cap, which is the cartilage. Now, initially, the cartilage undergoes softening, and then eventually it thins out. And then when it comes to stage 3, it thins out to a very minimal amount which is left, and the underlying bone becomes thickened and hardened, and eventually the entire bone gets exposed. And at this point of time, the patient has severe pain in the knee or in any joint which is affected. So causes of osteoarthritis could be divided into 2, which is the primary osteoarthritis and the secondary osteoarthritis. Primary osteoarthritis is purely wear and tear and is usually associated with age, whereas secondary osteoarthritis is caused by either trauma, infection, or other inflammatory conditions such as psoriasis, gout, or rheumatoid arthritis. On my right, I have a few pictures to show how these various types of inflammatory conditions could be picked out. So basically, on the top right-hand corner, we have this picture of a hand, which has got this red color rash, which is on the fingers, as well as the dorsum of the hand. And this is usually very thick and red in color. And this is classical in psoriasis patients. On the right-hand side to that, we have a picture of a hand with swellings at the joints which are very knobbly in appearance, and sometimes they discharge chalky white material. And this is very classical of gout. The lower end, we have a picture of a hand as well. This picture shows a hand with fingers which are deformed, and the joints or knuckles become very swollen, and every part of the joint, the interphalangeal joints are all swollen. And this is very classical of rheumatoid arthritis. So what are the signs for us to pick up if we want to know whether we have got some form of osteoarthritis? Now, the most classical or most common presentation is deformity, either a knocked knee or a bowed knee. Patients could have reduced joint motions, and as the disease progresses, the amount of mobility becomes reduced, and the distance that the patient can walk or bend their knee becomes very, very limited. In some patients, they present with a grating sensation in the knee. They usually can feel the grating sensation. Occasionally, it becomes so loud that even somebody who's sitting beside them would be able to listen to it. And the other sign is pain or tenderness along the joint line, especially if it is in the knee, at right beneath the kneecap. So these are some of the signs that are quite classical of osteoarthritis. Now, most of the time, osteoarthritis diagnosis can be made clinically. Occasionally, we need blood and radiological investigations to rule out other conditions. So blood investigations would encompass inflammatory blood tests to rule out if the patient has got gout, rheumatoid arthritis, and other inflammatory conditions. Radiological investigations, usually an X-ray is sufficient enough to make a diagnosis of osteoarthritis. Rarely someone needs an MRI to make a diagnosis of osteoarthritis of the knee. Now, on my right, we have an X-ray of a normal knee. Usually, we request for a standing X-ray. That's the thigh bone, and the one beneath is the leg bone, which is called the tibia. And the round shadow that you can see here is the kneecap or the patella. Now, this black band that we can appreciate in this X-ray is the full thickness of the cartilage, which is usually anywhere between 6 to 8 millimeters in thickness. These three pictures in this slide goes to show the different stages of someone who has got osteoarthritis in the knee. The top is the X-ray, and the bottom is the diagrammatic representation of the X-ray. So basically, that's the thigh bone and that's the leg bone, and that black band is the joint space. So if you look at this diagram, you could see that you can appreciate that the joint space on the inner side, it has become very, very reduced. And the next picture shows similar X-rays, but now we cannot appreciate the joint line at all. So it's bone on bone already. And the third picture shows some bone spurs, reduction in joint space, which is very significantly reduced, some what you call cysts forming in the bone, and the bone has begun to become bowed, and there's already loss of cartilage and some amount of bone loss. This picture is a picture of one of my old patients. She has bilateral knee osteoarthritis. You can appreciate that she has got bowed knee. She's also got a scar on her inner aspect of her leg where she's had a heart bypass surgery prior to this. And this is the back or a posterior view of her knees. You can appreciate how bowed her knees are, and she cannot walk without the aid of a walking frame. This is a picture of another patient of mine who came all the way from Perlis. She was actually bedbound, and she moves around the house by crawling because her knees are very, very painful, and she's unable to bear weight on her knees. And if you look at her X-rays, it shows severe bowing of both joints. There's hardly any cartilage left, and not only the cartilage is lost now, she is already beginning to lose bone because of the friction between both the bones. So this is very, very severe already. This is another picture of a lady who has got osteoarthritis of the knee. She's got knocked knees. Her right knee is going outwards. Sorry, it's knocked. It's inwards, and the foot is going outwards. And you can appreciate her feet and her toes are all bending, able to stabilize her knee. And these are her X-rays, and you can see how bad her bowing on the X-rays are. Instead of being straight, now the knees are completely bowed and the cartilage is lost completely. So how do we keep our joints healthy? We can do many things to make our joints healthy. Now, one of the most important thing is to get moving. When we move, we can maintain the motion of that particular joint. So if we have got severe pain, we have to find remedies to reduce the pain, and we have to get moving. If we don't move, the envelope of function will continue to reduce, and it'll come to a point where we can hardly bend or straighten the knee. So among the things that we can do, which is very common among our Asian population patients, are either Tai Chi or yoga. This is a very comprehensive form of exercise where you move almost every joint in the body, and the movements are not in a very vigorous way. It's done in a very gradual manner. It stretches the muscles, the ligaments, and also gives mobility to the joints. And one should also learn to protect his or her joints. How do we protect our joints? We must not abuse our joints. We know when our joints are painful, we shouldn't be climbing excessive stairs. If our joints are painful, we should not be doing high impact sports. And if we need to do some sports, we probably need to wear a knee guard and wear proper shoe wear, and make sure the place where we are doing our exercises is meant for an exercise. Also, managing one's weight will help a lot in reducing the pressure on the joint. Each kilogram lost from the body weight actually reduces the burden on the joint by 4 kilograms. The other important things that we should adhere to is we should stop smoking, and we also should eat well. There are many diets that have been proposed as good for one's joint. One of the most highly spoken of diet is the Mediterranean diet, where it has a very high content of fruits, vegetables, grains, mostly whole grains, olive oil, beans, nuts, legumes, seeds, herbs, and spices. And of course, increase the amount of fish and seafood, as fish contains lots of omega-3 oil, which is essential for our joints. Now, pharmacological means of reducing pain has two main groups of medication. One is the NSAID plus the COX-2 inhibitors, and the other is the opiate groups. Now, the NSAID group example, which many of us would have used in our daily practice, is either Indosit, Voltaren, Brufen, Naproxen, or the COX-2 group, Celebrex, Acoxia. Whereas the opiate group is Tramadol and Ultracet. Now, the opiates are better to be used for long term because they do not have any side effects to our kidneys and to our stomach. Whereas NSAID groups could be utilized in an acute phase where there's severe pain. However, this should not be continued on long term because it may cause kidney damage and cause ulcers or gastric ulcer disease or peptic ulcer diseases. So one must be very watchful of these medications they are taking, and ideally with the consent or with the discussion of the physician who's looking after them. Other options include disease-modifying drugs such as glucosamine sulfate or chondroitin. This acts as the building block for cartilage. It doesn't reproduce your cartilage, but it increases the viscosity of the joint fluid, reduces the inflammation, and allows better mobility. The other option is to use intra-articular injections. There are two forms of injections that are usually utilized by doctors for joints. which include steroids and hyaluronic acids. Um, Both have their own uses. Steroids is usually for an acute setting where the pain is very severe and there's a lot of inflammation, whereas hyaluronic acid acts more as a lubricant and to reduce friction and also to reduce wear and tear. The other thing that some patients use is if they have got a bowed knee, they can actually use braces. These braces allow to stabilize the knee. Let's look at this picture on my left. This is a picture of a person with left knee which is straight and the right knee which is bowed. They could use this kind of a brace to straighten the knee. And this is a picture of one of my patients who had bilateral knee issues, and she utilized this brace whenever she walks around, and that straightens the knee a bit and reduces the pain in the joint. So, and that also allows her to have good mobility of a joint. And that preserved some amount of cartilage until very many years later, only she had to have surgery. So the other option is, of course, surgery. Surgery involves a joint replacement. Total knee arthroplasty is an effective treatment for severe osteoarthritis. It leads to good results in returning to daily activities, has good survival rates, and overall functional improvement. In fact, knee arthroplasty surgery has been a very long-standing surgery and is one of the few surgeries which have got a very high satisfaction rate among a lot of patients. This picture is a picture of the earlier patient whom I showed with bilateral knee osteoarthritis with a bowed knee. Imagine when she went for surgery, her entire thigh bone, which is on this right side, had a small crater. And this is the front view. You can imagine the whole bone was already lost, and cartilage lost, bone lost, and there was a huge crater in the thigh bone, which need to be resected. Now, so of course, this is in a very, very severe case. So the options of joint replacement cannot be forgotten, because many of our patients end up with severe osteoarthritis, and joint replacement is an important part of the treatment. Joint replacements or total knee arthroplasty is already an effective surgery, and the aim now is to further improve patient satisfaction and functional outcomes. So a lot of research and money and time has been spent to come up with better procedures to get patient satisfaction and better functional outcomes. Different types of new technologies have been developed over the years to improve surgical accuracy and to improve patient satisfaction. So when there is a better improved surgical accuracy, that means the implant will last longer and patients do not need to go for a revision surgery very quick. So there are newer knee arthroplasty implants these days with wider ranges of size. You often sometimes hear that patients say that, oh, probably they didn't get my right size. So that's unlikely to happen nowadays, because we have got wide ranges of sizes in increments of 1 to 2 millimeters. And we also have implants which are gender specific, which I will elaborate later. And we also have implants which are custom made for very special patients with very different kind of the bone pattern. So these things are conceived, designed, and to reproduce the native pre-arthritic anatomy of the knee. So this picture goes to show there are many different types of implant that is available in the market. Each has its own advantage for different patients to suit their needs. A gender-specific knee basically means an implant which conforms to the female bone morphometry. So it's not one that fits all. So we have one for female patients and one for even male patients. So the female patient implants are usually less broader as compared to the male patients. Custom-made implants, like for some patients who have got congenital deformity, like dwarf patients, they may not be able to use the regular implants that is available off the shelf. So they need to have custom-made implants. Compartment-specific implants are implants that are made specific for a certain compartment. In this picture, we can see the operative picture. This is the kneecap. That's the end of the thigh bone. We can see the end of the thigh bone is almost pristine. Whereas the same patient's operative picture, you can see on this side, kneecap is almost all of it is destroyed. So in this patient, the patient doesn't need to have a total knee replacement, but the patient can have what we call as a patellofemoral joint replacement, where we change the area of the cartilage which is lost in the kneecap with a small button. This is an X-ray of a patient who has got unique compartment disease or a one compartment disease. So this X-ray shows that this is the inner area, that's the outer area. We can see in this X-ray, the outer area cartilage seems to be well protected, whereas the inner area, the cartilage is all gone. So in this patient, it will be a waste to do a total knee replacement, because then you'll be sacrificing unnecessary ligaments, and would not be near natural. So in this patient, what we do is a unicompartment or a partial knee replacement. So this picture shows the implant that we use in a partial knee replacement. It's a single radius, one condyle implant for the top, another metal implant on the bottom, and there's a high density polyethylene. So in this middle diagram, you can see the cartilage which is damaged is now removed, and this implant is inserted into this area, and that's the end product. This last picture is a surgical picture showing a patient who has had a unicompartmental knee replacement. And in fact, in this patient, you can see this metal, which is black in color, which is oxenium, which is another new development, which is material with very long-standing outcome results and very good, very low friction rates, and hence very little revision rates. This next slide shows a bicompartment arthroplasty. That means there are two compartments. The knee has got three compartments. So when the disease only involves two compartments, we don't need to change the third compartment. It's just like when you have four wheels in a car. If you have only two wheels, two tires which are spoiled, you only replace two tires. You don't need to replace all the four tires. Then we have the option of computer-aided surgery. Now, computer-aided surgery is something that has happened in the past 10 to 15 years. There is significant progress made in computer-aided surgery. So basically, computer-aided surgery is a surgery where the computer is used as an assistant to the surgeon when the surgeon is doing the surgery. This is a picture of me and my team doing a computer-aided surgery back in 2005. So basically, we put the input of the patient's bone morphometry into the computer. The computer will digest it and tell us how to make the cuts on the bone to get a precise or an accurate placement of the implant. So computer-aided surgery allows the implant components to be implanted with greater accuracy. It reduces blood loss, reduce incidence of transient hypoxia or confusion as a result of release of blood fat products into the blood. It reduces surgical and radiological outliers. Hence, there's better surgical outcome and increased implant longevity. At the end of the day, we want our implants which are put in to last as long as possible, if possible, a lifetime. Now, the most recent development that we have is robotic assisted knee arthroplasty. Robotic assisted knee arthroplasty is also available at Sunway Medical Center. The hospital has invested in purchasing these robots in order to have good outcome for our patients. So robotic assisted surgery is surgeon-centered. It's very accurate and reproducible, and it's efficient. So basically, a patient walks into the clinic, makes a decision that he or she wants to have a knee replacement. We send the patient out for an X-ray. The X-ray has got some what do you call markers to calibrate the size of the bone. And then that X-ray is now reconstructed with a 3D scheme. And then it's the whole contour of the bone is mapped out. And then the bone, mean bone positioning is accepted and what kind of implants we want to use. And all this is fed into the computer, and the computer will then digest and then tell us what we need to do with the robotic surgery. And when the information from the computer is now fed to the robot, and the robot will assist the surgeon in doing the surgery. So this is how the robot arm looks like. And this picture shows the robot arm here. The surgeon still has to hold the saws and the instruments to cut, but the robot will place itself to make sure that the cuts are made accurately. For example, this is a picture of a 2 millimeter bone cut that we planned out to do, and it's so reproducible by using the robot. This is a picture of our first robotic surgery in Sunway Medical Center. Basically, this is me and my team. You can see the number of instruments that are needed in a robotic surgery is very, very few as compared to the conventional method. This is the robot camera, and the robot is on my left-hand side. So it's pretty neat operating theater setup using the robot. This is a video which shows how the robot arm comes and how it is placed on the bone. And once it's placed on the bone, you can move it sideways, but its position doesn't change at all. So the accuracy of our cutting is almost as good to the final 1 degree. So new technologies are available, and they are very attractive and have constantly evolved. They expand the possibilities and the surgical indications. They improve our knowledge of knee biomechanics. They try to restore the native knee function. So when we restore the native knee function, the patient's muscles and ligaments can conform to this new joint much easily. New technologies, at the end of the day, better surgical outcome, they increase the implant longevity and they increase the patient's satisfaction. These last few slides show some of the patients who have had surgeries with us. This is how the surgical scar, heel surgical scar looks on a patient's knee. This patient, after having a left knee, has come in for another surgery for the right side. You can see on the lower picture, the right side is just bandaged. She just had the surgery, and the left knee is post-surgery. And you can see how well the left knee she can actually bend. A lot of my patients always have this question or myth that after the surgery, they cannot bend their knees. No, the current implants allow the patients to bend their knee quite significantly. This is another happy patient who had both his knee surgeries done. And after his knee surgery, he is able to go back to his original usual way of praying. He's able to sit cross-legged, and he's able to do a full squat. So yes, total knee replacement surgeries are very gratifying. They offer very good results. They have their own risks and complications, but if it's done well, it will last a lifetime. And with the advent of newer technology, obviously, it has made a significant improvement in the longevity of the implant. Before I end my lecture, this picture on the left is the robotic surgery that we did in Sunway Medical Center. That's the robot, and that's me holding the saw, and that's how precise the cuts can be made. And this is one of the robots that our hospital has acquired. With that, I would like to thank the organizers for giving me this opportunity to present. And if any one of you have any issues or any questions to ask, we'll be more than happy to entertain you. If you have more questions after these lectures, you can always contact Sunway Medical Center for us to give you a better explanation on the procedures that we offer. With that, thank you.
Thank you very much, Dr. Suhail, for that very interesting session with us. We have quite a number of questions that have come in from our participants. Certainly a reflection of the interest in the topic as well. So if you're okay, I'll get started with the first question right now. And from G. Grace, who asks, if someone has lost both legs, the collagen in both legs, and physiotherapy is done for 6 months, how can they prevent further deterioration?
Hi, Raj. Can you hear me?
Hi, Doctor. Yes, loud and clear. Thank you.
All right. Okay, great. Fantastic audience. I see the questions coming in. But before that, I would like to thank the organizers for putting up this, this session. And Mrs. J, I enjoyed your dance video. My feet is still tapping on the floor. So thank you. Okay, first, let's go to the first question. Someone asked about collagen.
Shall I repeat the question again?
Yeah, okay. Raj, can you repeat the question for me, please?
Yes, of course. Just give me a second, yeah? Okay, this is from G. Grace, and she asked if someone has lost the collagen in both their legs and has had physiotherapy done for the last 6 months or for 6 months, how can they prevent further deterioration?
Okay, first, let me just make some corrections first. Now, usually in a case of osteoarthritis, the issue is not so much of losing just the collagen, it's losing the cartilage. And there's an inflammation, and also there is a cartilage loss component. So yes, physiotherapy will help. What the physiotherapy does is it allows you to strengthen your muscles. Hence, it's able to support your body weight, support your knee, and also strengthen your ligaments. That's number one. Number two, the physio will also teach you how to move your limb, your joints to bend and straighten, and also how to keep your joints supple. That means you already have a function which is deteriorated. Example, my function when I'm 25 years old, the function of my knee is 100%. Now with osteoarthritis, I may have dropped to 75%. What you want to do as you go on is you want to reduce stiffness in your joint so that your range of motion or your motion is preserved. So yes, physiotherapy is important. So going forward, after the physio you have learned, you can continue those exercises. You don't need to see the physiotherapist for the rest of your life. But what's important is you practice those exercises that are given to you. Occasionally, you may need to go back to rehearse or review some of the new exercises that need to be done. But you can continue doing that. And then on top of that, healthy lifestyle, eat well. We spoke about good diet. We spoke about preventing excessive body weight and not abusing your joint. Yeah, so these are the few things that you can continue to do.
Thanks, Doctor. The next question is from Melinda Howe, and she asks, does taking glucosamine and chondroitin, I hope I've pronounced that correctly,
Yeah, you're right,
help to prevent further degeneration? And she's also asking, what's the best supplement to take? Okay,
now, basically, glucosamine and chondroitin are building blocks of your cartilage. So if I have osteoarthritis of my knee already, and if I take glucosamine plus chondroitin or glucosamine alone, what will happen is it offers me, one, it increases the viscosity of the fluid. That means my joint fluid becomes more thicker. By that, there is less friction and less wear and tear. That's number one. Number two, it prevents the reduction of the cartilage significantly. That means to say, in a year, let's say if I'm losing 0.5 millimeters of cartilage, I may be losing now with taking this protection probably 0.3 or 0.2 millimeters. But mind you, it doesn't stop, because as long as we live, we move. And as long as we move, there will be friction. And as long as there is friction, there will be reduction in cartilage. So yes, it will help, but it will help to reduce the wear, but it doesn't stop.
Great, thanks, Doctor. Another question here from Sharon Su, and she's asking if it's advisable for seniors to consume calcium supplements, and if so, how much is recommended?
Okay, now appropriately, if you take our regular diet, and if you're not too fussy about food, and if you're not too picky about things, our regular diet already contains significant amount of calcium. But when we all grow older, like when I see my grandmother or even my late father and mom, when they eat, they don't take a full meal. So the diet is already very little. And then they become very particular with things that they can and they cannot eat. So with that, you will need to have calcium supplement as you age. So the answer is, if you're not eating well, you need calcium supplement. How much? 1,200 milligrams. Yeah, so that's how much calcium you need.
Okay. Sharon, I hope that answers your question. A very short one. I'm not sure if it's a complete question, but Judy is asking about, in relation to joint health, what about stem cell therapy?
Okay. Stem cell therapy is an option that's available. As of now, in Malaysia, stem cell therapy is still at the verge of, at the level of research. One or two centers in Klang Valley have been designated by the Ministry of Science and Technology to be allowed to do this research. Hence, it's not freely available in every hospital. And because the verdict is still out there, many of the hospitals have not gone into it fully, totally, as far as cartilage is concerned, one. And the second thing is, if you are using your insurance to get any of this therapy, your insurance will not cover stem cell therapy. So yes, there is an option available.
Okay. Great, thank you. A question from Nova, who says, I'm having signs of knee osteoarthritis. Should I be stationary? It would take a while before I could move without the pain. But once I start walking, the pain is gone. Do I need surgery to correct the problem?
Okay. Basically, a joint's function is to give you mobility. So if you don't have a joint, it will be like a hard stick, long stick, right? So yes, if you have osteoarthritis, one of the things apart from pain is stiffness. So if you already have osteoarthritis, when you want to get up and walk or move, or if you want to change positions, you want to do it gradually so that you can allow your ligaments to stretch, the joint capsules to stretch, and then be able to walk. And then once you start walking, you probably don't have so much of pain because the stretching is already done. But then the second part will come, where if your cartilage is severely damaged, then you will even have pain when you walk. So do you need surgery? Surgery is based not only whether you can walk or not. The usual indicator that we have when we decide somebody needs a joint replacement is the person has severe pain and all other modalities that are available in terms of lifestyle changes, medications, and all that has failed. Only then surgery is considered. So now we usually don't dive into surgery as a first option.
Okay, great. We just have time for one last question, Doctor, and that is from Mince Chin, who's asking if this particular issue is more prevalent in females compared to males. Has this anything to do with females being more susceptible to osteoporosis?
Okay, a very good question. Now, the ratio is between females to male is 3.5 to 1. So for every 3.5 ladies, you can probably get one man who has got a male patient who has osteoarthritis. And we know there are many causes for osteoarthritis. Now, in my lecture, we spoke about inflammatory arthritis, we spoke about infection, we spoke about trauma, fractures, and all that. So if you take all that out, if you talk about primary osteoarthritis, that means there are no other confounding factors to cause, and it's just purely with regards to age. Even in that group, the females outnumber the men. So why is that a reason? So first of all, because of the menstrual cycle and the hormones that are available, most females have a slightly more lax ligament compared to men. And this is time and again proven. If we look at female athletes, many of the female athletes end up having more ligament tears and injuries compared to men. So for that, the answer behind that is ligament laxity, number one. So when you have ligament laxity doesn't allow your knee to be supported well, and then your cartilage gets worn off faster. That's number one. Number two, post-menopause, many of the ladies end up putting on more weight. And when there's an sudden increase in body weight, that puts a lot of burden on the joints. And that is also another reason why females are more susceptible to osteoarthritis compared to males. Yep.
Great.
And it's not really, and it's not entirely due to osteoporosis. Yeah.
Okay. Dr. Sohail, once again, thank you very much for your time today and for your very interesting talk. Ladies and gentlemen, we have come to the end of the presentation by Dr. Sohail of Sunway Medical Center. Thank you once again, Doctor. And,
thank you, Raj. Thank you.
Yeah. And coming up next, folks, the next talk that's coming up in the next 5 minutes or so will be a webinar by the Securities Commission of Malaysia on how you can avoid investment scams. Now, this is very interesting. We read and hear so much about all sorts of scams, and what the Securities Commission will be looking at is how you can avoid investment scams. So stay on. We'll be back in about 5 minutes. Thanks very much, and we'll see you in a bit.